My name is Dr. Singh ISHAR, and today is 10th of March 2017, and I will be talking today about hypocalcemia. I got a lot of requests by my students and by my friends to do some online lectures, and this is the very first one today, so I'm a little apprehensive also. The topic for today's discussion is hypocalcemia. As we all know that the normal serum concentration of calcium is between 8.5 to 10.5 milligrams per dl, or if we'll talk in terms of millimoles per liter, it's 2.1 to 2.6 millimoles per liter. Any serum level below these normal limits is called as hypocalcemia. What people often think about hypocalcemia, that's wrong. What they think is this, that it's a neurological disorder. No, it's not a neurological disorder. And remember that the most important thing whenever you are going to interpret the serum calcium levels is to check the serum levels of albumin, because for drop of every 1 gram per dl of albumin from the lower limit of the normal will cause a drop of serum calcium by 0.8. So if the serum calcium is, for example, 6 only, and you will think it's because of hypocalcemia, because of any cause, but at the same time if you'll estimate the serum albumin levels and they'll come out to be just 1 gram per dl, they'll come out to be only 1 gram per dl, then you have to multiply 0.8 into 3. So you have to add 2.4 milligrams per dl in that serum calcium of 6. So that will be around 8.4. So that is normal. Okay. Now we move on to the etiology of hypocalcemia. In the etiology, the most important thing is primary hypoparathyroidism. We are having four small parathyroid glands which are present in the posterior aspect of the thyroid. So any type of surgery around the neck area, any thyroid surgery, or in the olden days when people they used to do thyroidectomies for hyperthyroidism, or sometimes when somebody gets operated for papillary carcinoma of thyroid, because these glands are so small that they may get removed accidentally. So this is something which is not hidden in the history. So you specifically ask that particular person that whether there is a history of any surgery around the neck area. The second important cause of hypocalcemia, apart from primary hypoparathyroidism or acquired hypoparathyroidism to be more exact, is vitamin D deficiency. And the vitamin D deficiency can arise because of bizarre number of causes. One of the most important causes is the renal failure, and there is going to be no 25 hydroxylation. Another important cause is liver failure, where there is no 125 hydroxylation, the final step over there. And apart from these two, certain malabsorption states, intestinal malabsorption states like celiac sprue, very rarely tropical sprue, but usually celiac sprue, and sometimes in the setting of chronic pancreatitis. So in the etiology, if you have to remember something, the most important thing is first is the acquired hypoparathyroidism, and the second one is vitamin D deficiency. Sometimes they specifically ask you that what you should always check when you are uh, doing workup of a patient of hypocalcemia. The answer is the serum magnesium levels. The reason is this, that for the normal secretion of the parathyroid hormone and for its final action on the parathyroid receptor, you need magnesium. So if somebody is having deficiency of magnesium, there's going to be no secretion of PTH, and if there is no secretion of the PTH, that is going to affect your homeostasis of the calcium metabolism. So it will get disrupted. So that's the reason that why you always check the magnesium levels in all the patients who are having hypocalcemia. Then there are certain drugs. We're not having a lot of drugs, but you have to remember about diuretics, and that too the loop diuretics, not the thiazides ones, because you know that the thiazide group of diuretics, they are associated with hypercalcemia. So this is the only effect which both these drugs, in which both these drugs they differ. Otherwise, all the effects on glucose, lipid, sodium, potassium metabolism is almost the same with loop and thiazides, except this one, that thiazides are going to cause hypercalcemia, whereas loop are going to cause hypocalcemia. Though thiazides initially when you give them, they again cause hypocalcemia, but we are talking about the overall effect, which will be seen after a couple of days, and that is hypercalcemia, not the hypocalcemia with thiazides. Then all aminoglycosides, they are known to cause hypocalcemia. There is one another drug which goes by the name of foscarnet. Foscarnet is used for the diagnosis, for the treatment of CMV retinitis, for the treatment of CMV retinitis, and sometimes it's also used for herpes simplex virus infections. So do remember that this is another drug which can cause hypocalcemia. And then plicamycin, it's a obsolescent drug, not used much these days. In the older days it was used to treat hypercalcemia, but we are not using this drug these days. So loop diuretics, thiazides, plicamycin, and foscarnet. Okay, now going to the clinical features. So the clinical features, they are because of increased excitation of the nerve cells and the muscle cells, and because of this increased excitation it will affect the neuromuscular and the cardiovascular systems, and it can cause spasm of the muscles, it can cause tetany, bronchospasm, jitteriness, and sometimes seizures. They are also seen. The cardiac symptoms, they are a little less frequent, but these patients may develop sometimes syncope, and they may develop bradyarrhythmias, rarely. Coming to the two important clinical signs which are described with hypocalcemia, one is the Chvostek sign, another is the Trousseau sign. Chvostek sign is this, that in front of the earlobe, around 3 centimeters in front of the ear lobe, or around 1 centimeters below the zygomatic process, where the muscle is masseter. So you have to tap over there. On tapping over there, here there is the facial nerve, it is coming out from the stylomastite foramen. So because the threshold has decreased, that person will be having twitchings, and he'll be having twitching of the nasal, or the nasal bridge, a little of nasal bridge, little bit of nasal bridge, and that of the buccal area. So he'll be having lateral deviation of the nasal fold, to be very honest, and the buccal, the surface of the cheek, the outermost surface of the cheek, there's a lateral deviation. Trousseau sign is that you have to inflate the blood pressure cuff, and you have to keep it for 3 minutes above the systolic blood pressure. And because you are kind of cutting the circulation, so that will evident in the form of spasm, what you typically call as carpal spasm. People they say carpopedal, it's not pedal, pedal is the foot, so it's a carpal spasm. And in the carpal spasm, the metacarpophalangeal joints will flex and the fingers will adduct. Apart from this, checking the serum albumin, checking the serum magnesium, if you'll do an EKG or ECG, you'll see there is a prolongation of the QT interval, a prolonged QT interval is seen with hypocalcemia. Now going with the treatment, treating the patient if he's having severe hypocalcemia, he's having bronchospasm, tetany, seizures, you have to be a little more cautious. And even if the features of latent tetany, they are positive in the form of Chvostek and Trozo, you treat them with intravenous calcium gluconate. 10% of 10 ml calcium gluconate you have to use, and the dose is 10 to 15 milligrams of calcium for every kg of the body weight. So most of the times people, they take 6 to 8 vials of 10 ml of 10% calcium gluconate. They put that 6 to 8 vials in around a liter of D5, and they infuse it over a period of 4 to 6 hours. And the reasonable goal is to keep calcium between 7 to 8.5 milligrams per DL. If somebody is having a mild to moderate hypocalcemia, not a severe one, then you can give oral calcium, 1 to 2 grams of oral calcium, and then along with that you can give vitamin D preparations. One important thing which you have to do is this, that once you have started a patient on mega doses of calcium, you should always check their urinary calcium levels, because sometimes these patients having hypercalciuria, and if it is present, that means they're having a calcium excretion of more than 300 milligrams in 24 hours. There's a red flag because it may cause renal failure. So you usually decrease the dose, because there's a risk that patient may develop renal failure in the coming time. Then apart from this, sometimes those patients who are having hyperphosphatemia because of renal failure, especially in the CKD stages 4-5 ESRD, it's very difficult. Basically, if you'll go by the medical literature, phosphorus is a very difficult ion to dialyze. So you have to keep the patient on some form of phosphorus binder, which will bind the phosphate. So phosphate binders you have to use. And apart from this, you have to tell them to do the diet manipulation, so as to take less of the food which contains enormous amounts of phosphorus. And this is the way how we usually diagnose, we treat hypocalcemia. Thank you.